Hello everyone, I'm Niharika, McMaster Radiology resident. Welcome to this lecture in which we'll cover radiographic manifestations of MSK trauma. The slides for this presentation were created by Dr. Adam Legg, who is an MSK radiologist at St. Joseph's Hospital in Hamilton. In this lecture, we will define a fracture and describe the relevant radiographic features, discuss special types of fractures, and then we'll go over some cases. So what is a fracture? Let's discuss the signs and descriptive terms. So a fracture is a discontinuity in a bone caused by trauma. Fractures can be completed or trabecular. In a completed fracture, the cortex and trabeculae are involved, resulting in two separate fragments of the same bone, as you can see is demonstrated on the image on the left side of the slide. At the level of the distal tibia, you can see two separate fragments of the same bone. In a trabecular fracture, on the other hand, there's no cortical discontinuity, so sometimes these are radiographically occult and self-limiting. A contusion is a more diffuse and confluent region of marrow edema, and it's apparent only on MR. Now, this is much beyond the level of this lecture, but just to show you an example on the right of the screen, we have coronal MR images of the knee, and in the bottom images, which are T2 fat set, we see bright areas on both the lateral aspect of the femur and tibia, which are demonstrating contusions. A couple of other terms that are important to know while talking about fractures are subluxation and dislocation. Subluxation is disruption of articular alignment in a way that part of the articular surface still remains opposed, whereas dislocation is complete disruption of the articular alignment where articular surfaces are no longer opposed. Now let's talk about the radiographic features of a fracture. So first we'll look at cortical discontinuity. In the beginning, when I first started looking at radiographic images, what I found useful was to actually take my cursor or visually trace out the cortex of each bone to look for a subtle discontinuity, which can then lead you to seeing a subtle fracture. So for example, on the image of the elbow here, if we are tracing out the cortex of each bone, as we get to the radial head at this level here, we see that there's a subtle cortical discontinuity, and so here there's a radial head fracture. Another feature that's useful to look at is trabecular alignment. So it's important in this case to look at multiple normal images to know what trabecular patterns of different bones look like. But for example, in the femoral head here, we can see some trabeculae running this way and some of them running this way, but then suddenly you notice this really bright area here on the bone that looks like it doesn't really belong. And then if you look further, there's some cortical irregularity here as well. So that leads us to pick up this very subtle femoral neck fracture in this case that might not have been very obvious at first glance. The next feature is periosteal reaction, in which the periosteum responds to injury by forming a new layer of bone along the surface of the underlying cortex. An example of that is shown here at the distal aspect of the second metatarsal of the foot. You can see evidence of periosteal reaction as well as the underlying fracture. Soft tissue signs can also be useful in the detection of fractures. So let's talk about swelling. When you look at the image of the ankle in this slide, if you compare the soft tissues at the medial aspect of the ankle joint and the lateral aspect of the ankle joint, you'll notice that there is soft tissue swelling at the lateral aspect. And this is also consistent with the underlying distal fibular fracture in this case. Another useful soft tissue sign is effacement of fat planes. So on the images on the right of this slide, we have two images of the wrist. The image on the extreme right shows a normal wrist where at the lateral aspect we have normal fat planes. Now on the other image, we see that the fat planes are effaced in that same region. And that leads us to further looking, and we see that there is a scaphoid fracture in this case. So again, effacement of fat planes can be another useful soft tissue sign. Joint effusion is another useful feature. In the radiographic image of the knee here, we see a large joint effusion, and that makes us look closer, and we see fracture lines at the distal aspect of the femur here. The following slides talk about some descriptive words that are used to describe fractures. The first one is transverse fractures. These occur when a bone is broken perpendicular to its length, and the fracture pattern is in a straight line that runs in the opposite direction of the bone, as seen in the example of the patella here. An oblique fracture is when a bone is broken at an angle, as seen at the mid-aspect of the tibia here. A spiral fracture is one in which the bone is broken with a twisting motion, and this creates a fracture line that wraps around the bone and looks kind of like a corkscrew, as seen at the proximal femur here. A butterfly fracture is caused secondary to perpendicular stress on a bone, and it results from two oblique fracture lines meeting to create a large triangular or wedge-shaped fragment, which looks like a butterfly, located between the proximal and distal fracture fragments. A comminuted fracture refers to a bone that is broken in at least two or more pieces, and in this case it's important to comment on the position of the dominant fragments. Now let's look at describing the displacement of a fracture. So if there is translation, we need to precisely give a distance or percentage and direction of displacement of the distal fragment in relation to the proximal fragment. And a couple of examples how we can describe this are provided in the slide. You can also use mild, moderate, and marked to describe the amount of displacement. In order to correctly describe angulation, you need to have two orthogonal views. To avoid confusion of whether the direction refers to the apex of the fracture or the apex of the distal fragment, it's good to specify. For example, in this case, we have apex ulnar angulation of the distal radial metadiaphysis fracture. Describing longitudinal displacement can help quantify the degree of impaction or distraction. Significantly distracted fractures are often avulsion fractures, as seen in the example of the greater trochanter avulsion fracture on the coronal CT image here. The next few slides will discuss how to determine the chronicity of a fracture. A fracture that is within the first week is in the acute and inflammatory phase. A fracture that is within the first week to the first few months is in the subacute and reparative phase, and from a few months to years, it's in the chronic or remodeling phase. In the acute phase, there is a cellular stage and a vascular stage. In the cellular stage, there is bleeding into the fracture defect, which creates a hematoma followed by tamponade and scaffolding. In the vascular stage, granulation replaces the hematoma, and there is resorption of bone at the fracture margin. This causes widening of the fracture defect in the late acute phase. Acute fractures usually present with a history of recent trauma, and radiographically, the features include sharp corners and defined margins, comminuted fragments that are not yet resorbed, exposed marrow without overlying cortex, and some of the soft tissue signs that we discussed earlier. Now, another important principle to talk about is the pretzel principle as pertaining to fractures of ring-shaped bones. The pretzel principle is an analogy used to demonstrate that if you try to break a hard, round pretzel, it usually breaks in more than one spot. Similarly, ring-shaped bones, such as the pelvis or the mandible, usually break in more than one place during trauma. So if you find one fracture in a ring-shaped bone, make sure to look for another fracture. The next phase in fracture healing is the subacute phase, and this can be divided into soft callus formation and hard callus formation. Soft callus is formed when granulation tissue evolves into fibrocartilage, which provides immobilization for osteoprogenitor cells. Hard callus is formed when the cells differentiate into osteoblasts, followed by fusion of fragments, which marks the end of the reparative phase. An entity to discuss in the subacute phase is that of heterotopic ossification. Our bodies love turning hematomas into bone, so much so that it happens in non-osseous tissue as well, including muscle, fat, and periosteum. Here you can see an example of calcification in the musculature of the medial thigh. Radiographically, in the subacute phase, soft callus is actually radiolucent and not radiographically apparent. It can, however, be seen on cross-sectional imaging. Hard callus, on the other hand, looks like a fluffy density around the fracture site, which gradually consolidates into well-defined bone. The residual surface defects are called clefts. Now we're on to the chronic phase where there is bone remodeling. Callus has fully been replaced by bone. The cortical bone is restored at peripheral margins, and over months or years, the alignment improves as well. The modeling deformity starts to slowly decrease in adults, but may completely resolve in children. Radiographically, in the chronic phase, there are smooth and continuous cortical margins at the site of the fracture. Marrow at the old defect may still look radiolucent, but any indirect signs of effusion or swelling, for example, have now essentially resolved. That was all about the healing process of a fracture in a normal way. But what happens when fractures don't heal normally? There can either be atrophic non-union or hypertrophic non-union. Atrophic non-union occurs when healing is limited by age, malnutrition, steroid use, or chronic disease. Hypertrophic non-union occurs due to absent or inadequate immobilization. Be cautious about the language around union because these terms have specific implications. These terms are relative to the site and patient demographic. The definitions of delayed union, malunion, non-union, and pseudoarthrosis are provided in this slide for your reference. Let's look more closely at pseudoarthrosis. If there is insufficient immobilization in the reparative phase, and adventitial bursa forms within the fibrous callus at the site of increased friction, healing is therefore limited, and the result is a synovial bursa within a fibrous capsule at opposed ends of two bones, forming a pseudo-joint. Anyone can undergo pseudoarthrosis, but certain populations are predisposed. And some common sites include the scaphoid waist, humeral diaphysis, distal tibia, talar neck, and clavicle. That brings us to the end of part 1, in which we discussed what a fracture is, how to describe a fracture, and how to determine which phase of healing a fracture is in based on radiographic findings. Now we move on to part 2, in which we'll discuss special types of fractures. Fractures through abnormal bone are termed pathologic fractures. There can be either focal pathology in the form of benign or malignant bone lesions, as seen in the top 2 x-rays here, or diffuse pathology as seen in congenital or metabolic disorders shown in the bottom 2 images. The next entity is fatigue fractures, which can be subdivided into stress fractures and insufficiency fractures. A stress fracture occurs when there is abnormal stress on normal bone. In this case, the background mineralization is adequate. The history typically involves excessive, repetitive activity, maybe with recent sudden increase. Females are more predisposed than males. An insufficiency fracture is characterized by normal stress on abnormal bone. In contrast to stress fracture, here the background mineralization is inadequate. The history includes some chronic disease or advanced age. Again, females are more predisposed than males. Radiographic features of fatigue fractures include hypertrophic callus or periosteal reaction, linear sclerosis, focal cortical thickening, or these can be radiographically occult, but on MR there will be signal abnormality and intense edema, or on bone scan, there will be increased uptake. High-risk fractures occur at points of tensile stress. So bones are pulled away by the offending force or physiologic demands. These usually occur in watershed zones with poor vascularity. Low-risk fractures occur at points of compressive stress, and in this case, bones will be pushed together. Low-risk fractures have a risk of progressing to completed fractures. Children have more plastic bones which deform rather than fracture. Note that there is still fracturing on a trabecular level, but just may not be radiographically occult and doesn't involve the cortex. A green stick fracture is a fracture that occurs when a bone bends and cracks instead of breaking completely into separate pieces. The fracture looks similar to what would happen if you tried to break a small green branch on a tree. A buccal fracture is when one side of the bone bends, raising a little buccal without breaking the other side of the bone. A torus fracture refers to a circumferential buccal fracture. Note that all torus fractures are buccal fractures, but not all buccal fractures are torus fractures. Plastic deformation or traumatic bowing is an irreversible change in the shape of a bone after an injury. This is a slide for you to read through, and it summarizes the Salter-Harris classification of growth plate fractures in pediatric population. I find this diagram very helpful in remembering the different types of Salter-Harris fractures. That brings us to the end of part 2, where we discuss special types of fractures. And now for part 3, the more fun part of the lecture. The following slides have some common MSK trauma cases. I will be discussing the answers as we go, but I encourage you to pause the video at the beginning of each case and try to come up with a diagnosis to test your knowledge. Here we go. There is an extensor tendon avulsion at the distal 5th digit. This is also known as mallet finger. There's a fracture at the neck of the 5th metacarpal, also known as boxer's fracture. Here we have a carpometacarpal joint dislocation. You can see the importance of getting multiple views. There's an avulsion fracture at the base of the 1st digit involving the ulnar collateral ligament. This is also known as skier's or gamekeeper's thumb. This is a triquetral avulsion fracture. This is also known as the pooping duck sign, where the scaphoid is the head and neck of the duck, the lunate is the body of the duck, and the poop part is the avulsed triquetral fracture. So let's look at these fractures and their eponyms. These are all distal radius fractures. The first one is a Colles fracture, in which there is dorsal angulation of the distal fracture fragment. The middle one is a Smith's fracture, in which there is volar angulation of the distal fracture fragment. And the third one is an intra-articular fracture of the radial styloid, also known as chauffeur's fracture. This name was derived from when chauffeurs would sustain injury due to direct trauma from starting a car with a crank. Here's another slide with 2 different types of fractures, and their eponyms are also commonly tested. The one on the left of the slide is a Monteggia fracture, in which there's a fracture of the proximal or mid-ulna associated with dislocation of the radial head. The image on the right of the screen is a Galeazzi fracture, in which there is a fracture of the distal radial shaft with distal radial ulnar joint dislocation. Here is an easy way to try and remember the two fractures. Here we have elevation of the anterior fat pad of the elbow on this lateral x-ray, which is compatible with hemarthrosis, and usually this is due to an underlying radial head fracture. Now, although subtle, in this case there is a small cortical defect here, but again, in real life this can be confirmed with further cross-sectional imaging. This is a supracondylar fracture. These are examples of an anterior glenohumeral joint dislocation. These are two different types of fractures caused by one or more anterior shoulder dislocations. The one on the screen left is a fracture of the glenoid, and this is a Bankart lesion. The one on the screen right is a lesion on the humeral head, and this is a Hill-Sachs lesion. This is an AC joint separation. These are three different types of spinal fractures. The first one is a wedge compression fracture. These most commonly affect the anterior aspect of the vertebral body, and they're considered single column and stable fractures. A burst fracture is a type of compression fracture which is related to high energy axial loading secondary to trauma, and it results in disruption of the vertebral body end plate, and it also involves the posterior vertebral body cortex. A chance fracture is an anterior wedge fracture of the vertebral body, as well as a horizontal fracture through the posterior elements and or distraction of the facet joints. This is an image showing common sites for pelvic apophyseal avulsion fractures. This is an ASIS avulsion fracture involving the sartorius muscle. And this is an AIIS avulsion fracture involving the rectus femoris muscle. Here's an open book pelvis fracture. You can see there is symphysis as well as left SI joint separation. This was a pathologic lesser trochanter avulsion. You can see a lytic lesion here, and this happened to be secondary to B-cell lymphoma. This is a typical look for bisphosphonate fractures. There are focal areas of cortical thickening with subtle end osteosclerosis. This is patellar tendon disruption with consequent patella alta, which means high riding patella. On the left of the screen is an avulsion fracture of the lateral tibial plateau, also known as a Sagant fracture. On the right of the screen, this image is showing some indirect signs of an ACL tear, including anterior translation of the tibia relative to the femur. There's a big joint diffusion. Of course, you won't actually be able to see an ACL tear on an x-ray, but these indirect signs should lead you to get further cross-sectional imaging. This is a fibular head dislocation. This is a Maisonneuve fracture, which involves proximal fibular fracture along with an unstable ankle injury, which, as in this case, may be widening of the ankle mortise and may also include a medial malleolus fracture. This is an ATFL avulsion fracture with the avulsed fragment shown here. Calcaneal stress fractures can be very subtle, and this sclerotic line represents a calcaneal stress fracture. These are different types of fractures of the base of the fifth metatarsal. The first one is an avulsion fracture involving the fibularis brevis muscle. The second one is a Jones fracture, and this is normally seen at the level of the metaphysis. The third one is a stress fracture, and this is seen at the level of the diaphysis. And the fourth and last one is actually a trick. This is not a fracture, this is a normal apophysis in a pediatric patient. And with that, we've reached the end of our cases and the end of the lecture as well. I hope you found this useful. Thanks for listening.